All right, everybody should have taken a break between the last video and this one. If you haven't, go ahead and pause this and take yourself a break, and we can get moving on into the next section. And I'm going to go ahead and kick that off. So we left off, the last author talked about EMS systems in great detail from the beginning of time for EMS with Napoleon down through what our systems look like today. And we're going to kind of touch on that again to reiterate it. I believe that the more exposure you'd have to different things, the greater the knowledge base you can retain. And again, if you got your notes, that's a good thing as well. So let's look at the overview of EMS systems again. As we know, the EMS started in 1966 here with the publication of the Accidental Death and Disability, the Neglected Disease of Modern Society. In Texas, it was actually around 1970-71 that EMS got kicked off, and true to point, it was started with the the funeral companies. The hearses had the abilities to put bodies in the back of their vehicles, and they would actually race to different accidents and different places where patients could be picked up. And there was kind of little mini wars at some point in some cities to get the business to take it off. If you haven't seen the movie, old movie Mother, Jugs and Speed, it kind of makes fun of how ambulance companies and nursing homes used to kind of fight over calls and race each other to the different scenes where people had accidents so they can get the patients and get the billing. When patients were loaded originally, the patient went in the back by themselves and the two attendants went into the front. And as things progressed and technologies and how we do things got better, we started bringing things into the back with splinting and bandaging, and then the amazingness of amazingness, we added oxygen to the back of a hearse, and it really started becoming the predecessor of what we have today with trained personnel and medications in the vehicles. Making this thing work here a little bit better. Advanced emergency medical technicians, what do we do? There is a fine line between the EMT and the paramedic, and the advanced EMT sits right between that line. And what we do is no longer look at a patient just for splinting, bandaging, and rapid transport. Now we're going to be invasive. We're going to actually put stuff in the human body. We're going to stick needles in the body. We're going to access venous systems. We're going to assess patients differently. We're going to put tubes down people's throat and maybe put medications down those tubes. It's a whole other concept, and I've heard a lot of students say, well, I'm just learning to do IVs and intubation. Well, if that's your thought process, you've missed the mark, because what an advanced EMT really does is understand the balances in the human body that can be altered in a minute way and really affect the health and well-being of the individual. So there's a little video here. I'm going to see if I can get it to play. I'm not sure if I can, but we'll try. And we'll look at a scenario on how an EMT would handle this versus an advanced EMT. Let's see if it plays for us. Try to click it again. Should get. All right, so there's our scenario. There's your scene. That's what you got called out on to the party over here at the park, and you have a young lady that clearly has a humerus that is no longer in the appropriate alignment, and you're now the advanced EMT called out for ALS support. You get there as the EMT, and all of us are EMTs in this class. You look at this patient, you're going to be like, well, I'm going to splint it and bandage it, and I'm going to make sure she's secure to the stretcher, and maybe give her some oxygen. I don't know, maybe if she's a little bit shocky, and get her over to the hospital and get her taken care of. Well, as the advanced EMT, you're going to look at it a little bit differently. Even as the EMT, that this young lady is going to end up in surgery somewhere. Well, you also know that she could become shocky because of what's going on. She could be orthostatic because of just the fear and the strangeness of having a broken bone that severe in her body. As an advanced EMT, not only would you splint it and bandage it like you would have as an EMT, but you may go a little bit further and actually go ahead and start IV access, maybe give her a fluid challenge to kind of counter off that shocky appearance that she's going to have with some issues that's going along with her being afraid and the new fracture. And then the other thing is, advanced EMTs are really masters of continuation of care. EMTs package, get to the hospital, and hand over the patient. Where advanced EMTs, you need to start considering as an advanced level provider, what is the next step in this patient's journey back to wellness? Well, we know she's going to surgery. We know that she's going to see a surgeon at some point. We know that when she gets to the hospital, pain management might be a nice thing to get. If we access an IV, not only can we give her a couple hundred cc's of fluid challenge to see if we can avert any kind of shock that would be coming as part of what's going on with her body, but we have access for them to give her medication as soon as we get on site. We have access for them to go ahead, if there's a surgeon available, to bring her over and go ahead and start the process of getting back to health and getting that arm repaired. So the ALS provider, it takes a step further, and you're looking at it down the road kind of medicine. You're not looking at right here, right now. We're really looking at down the road, and that's where the differences really start between EMT and advanced EMT. The first book that we saw come out that is a professional style was created by the American Academy of Orthopedic Surgeons. As you can imagine, it had a lot of orthopedic stuff in it, splitting, bandaging, structures of bones, and focus on how that we maintain the integrity of the actual skeletal system. Not so much in the way of medicine, because EMS hadn't brought in that medical component yet. That was still reserved for physicians in the hospital. And since the 71, since the 48 years of EMS has been running around this country, we're getting a lot of medicine in the field. If you look at areas like Austin, Travis County, the EMS that serves in the city of Austin, a tremendous service, probably one of the best in the country, and they bring in some of the best technologies, and the medics are working at levels that few medics actually get to see. But in 1971, the concept would have never been considered to have an individual who wasn't a physician in the field decompress a chest, intubate a patient, maybe do a crike on a patient, or even push some of the medications that we're pushing nowadays. It would have never been a possibility. Today, that is the case. And along with that, as we move towards the future, the idea is to standardize the EMS scope of practice. So that if you're in California and you move to Arizona or Boston or wherever, you're going to have the same abilities that you have now that you would have had when you were in that previous state. I can tell you that I went to Louisiana for one of the big hurricanes years ago, Hurricane Katrina, and I was down there. Their EMS system had been displaced, and they brought in medics from all over the country to perform 911 services for them as they were trying to rebuild and just recover. And I was down there on a truck. It was myself and then a couple Louisiana EMTs and a couple volunteers, and we were the 911 for the area. And we came, got a call for a motorcycle versus the road. The guy had lost his motorcycle at a high rate of speed and hit the ground face first and planted it. We get there, he obviously had dropped the lung, so I decompressed the chest, which is common practice here in Texas for medics in the street. And as soon as I popped the chest, the EMS people around me literally stood up with their hands up and walked backwards. And I was kind of concerned, maybe he saw a snake or something I didn't see, but the guy's sats returned, his pulse came back to normal, skin color looked good. Got him in the truck, got him going down the road, got line started. He actually regained consciousness and started talking to us a little bit. Got to the hospital and was met with a sheriff's deputy and a physician at the back door, and a little concerned. To take the patient in, gave a report, patient was doing well. The physician that took the report asked me to go speak to him in the hallway with the sheriff's deputy, and now I'm really concerned because I'm away from home and I'm getting to talk to a police officer. I'm not sure what's going on. So I go out there, and the police officer was a little bit, let's just say he was a little curt with me. And the physician said, "Did you decompress that chest in the field?" And I said, "Yes, sir, I did." And the officer, you could tell, was getting ready to put on the good cop, bad cop routine and forget all about the good cop thing. And the doctor said, "Where are you a paramedic from?" And I told him, "I'm from Texas." And he goes, "Sir, do you have protocols in Texas to decompress the chest in the field?" I said, "Yes, I do." And he said, "Do you have them with you?" And I said, "Yes, I do." And we brought the protocols in and showed him the protocols. And the physician told the police officer, "This is an emergency declaration. They're operating from the protocols from the state from which they arrived to us. It's totally appropriate." He did the right thing. But I came real close at that point by violating the scope of practice for a paramedic in Louisiana. At that time, it may be different now, but at that time I had violated the scope of practice for Louisiana and was looking at some real problems, to include practicing medicine without a license. But all that to say, the national scope, we're trying to make a national scope of practice, trying to get a thing like the nursing profession has with the National League of Nurses, that they have a published national scope. And I think that when we get there, and we will eventually get there, when we do get there, we'll see pay scales rise, we'll see technologies improve, and we'll see better practices in the field as a whole, and it will only be the improvement that the nursing industry saw as they put their system together. There's recognized levels of training. For the most part, 48 states recognize the National Registry kind of as the testing bar for most systems. You still have state regulations because we are registered in the states for which we work, and our legislatures put together our statutes and regulations for our scopes of practice. And then we have our local EMS people that take care of things. You know, we may be in a community where the emergency manager and the fire chief work together to make sure that everybody does the right thing. I've worked in counties before that were closed, where if you were an ambulance service and you were going to come into that county, you had to get permission from the county judge and the fire chief before you were issued a permit to work in that county as an ambulance company. I've been in other cities where come one, come all, and you had 50 different services running around in the same city, which was, it was good for medics finding a job, but it was bad for the streets, and I think the city wasn't as safe with people trying to do emergency services everywhere all the time. But we have to be able to follow all these different regulations at all the time, and we have to remember that there is a hierarchy in EMS. We are able to do what we do because the legislatures have passed laws and regulations allowing us to have our license and allowing us to perform our skills in the streets, and all of that is, in Texas anyway, directed under medical control of the physician's license that we are working under. So we don't have any ability to work around the patients without that medical doctor saying that we are allowed to do what he has approved for us to do. And it's very important that we honor that protocol standing or online and make sure that we're not violating that medical director's license. It's important that we work with lay people to do some training and education and make sure that they understand what they can do. 10 years ago, you wouldn't find as many people that even knew what CPR was as we do today. I mean, with the advent of the internet, it's a small world no matter where you're at. And now you can't go into any place that's majorly populated, like a mall or whatever, without finding an AED and dozens of people that are available to do CPR. I can remember back in 1998, I was in a mall in a little town in Texas. I just got off shift where I was a supervisor for EMS, and standing there waiting to go into a movie theater with my little girl, and she was very small at the time, and older man in front of us literally just fell backwards with straight legs, stiff, and hit the ground hard. And he hit the ground, took about 3 agonal breaths, and became apneic and pulseless. And I started doing compressions on him. And literally people just kind of stood around and watched. And as they stood around and watched, I asked anybody if they could do CPR because I had an AED in my truck. And at that point, nobody knew what to do. So finally, after several people had just kind of stood around watching, we had a nurse that recognized me from the local hospital. She came up and she took over CPR, and I ran to my truck, got my AED, and came out, and we defibrillated the guy right there on the spot. And people were just astonished that this little piece of equipment that I had, of course back then it wasn't all that small, was able to, in their words, restart the man's heart. And it talked to you and it told you what to do, and what high-tech, amazing, technology that we had for EMS and emergency services now. Man, you find one of those in every elementary school now, every high school, every business that has a large population where people congregate. We find AEDs, and that's a good thing. We've moved in the right direction, and we're teaching people to use them, and that's a really good thing. From the layperson, we go into the first responder, and the first responder is not just limited to those people who take the emergency first responder course. Our law enforcement now, if you watch much cops or live PD, you see that law enforcement is carrying Narcan, which just not too long ago was reserved for paramedics. And now we got our police officers carrying it. They're trained, and I see it coming very soon into the EMT hands, and definitely into the advanced provider, the ALS advanced EMT's hands to use in the field as well. Firefighters, most of your fire services now are requiring that their firefighters be some level of medical trained. Be that EMT or EMR, and maybe as much as paramedic, depending on what kind of resources they have that they can allocate to salaries for their people. Park rangers, they have an interesting job in that they're isolated and they're identified as a singular unit by themselves in the middle of nowhere. So they have to be very well trained so that they can get to you, get you out, and get you to a place where an ambulance can actually get to, or where a helicopter can actually get you to pick you up. So they have a unique role as a first responder. And then if you've ever got to witness how ski patrol works for EMS, it's astonishing. These people, not only do they have to have the basic skills of EMS personnel, but they have to understand how to navigate themselves through roads that are impassable, using equipment in extreme conditions, and trying to keep fluids warm so that they don't give patients more hypothermia by putting cold fluids in their veins. It's really an amazing adventure to watch. If you've ever had a chance to do some training with those guys or have a class from one of them, it's really a neat opportunity, and you should take advantage of it if you can. The medical responders, they may or may not be trained under the Good Samaritan laws based on whether they're with a service and on duty, but for the most part, as they are not paid and they're volunteering their time, then they will be covered under the Good Samaritan law, and hopefully have themselves staying out of court as much as possible, which is always the goal for all of us. The emergency medical technician course, this program says it's around 150 hours, which can be true. That's based on your didactic as well as moving into the field. I know that for our EMT course, as well as the paramedic course that I took years and years and years ago, not only do they have a minimum hour requirement for the classroom, they have a minimum hour requirement for the truck and for the hospital, and then they have a minimum patient count for a patient that qualifies. And what that means is for an EMT, for have a patient that qualifies, they need a patient that they started vitals on, that they assessed, and that they did some kind of treatment on, be it help the paramedic with an IV, or help splint and bandage, or help set up a respiratory treatment, or put the patient on oxygen, that kind of thing. So if you have a patient that didn't qualify because you didn't do a treatment, then your hourly count really doesn't matter, because you've got to get your 10 patients. And for our program for advanced EMT, it's the same. When you go to the field to do your clinical rotations, you will need to have a patient that qualifies as a patient you treated. And patient treatment would include not necessarily an intubation, because you're not going to get intubations all the time, but you definitely want to have a patient that you assessed and that you at least started a line on, and maybe even flushed a line, so that you can say that that was a qualified patient and have your access that you need to do going forward. Paramedics, this says 800 to 1,500 hours. I think that's a little on the light side. Most paramedics that I know, that 1,500 hour requirement went way past that by 500 to 700 hours, I would think. They're trying to move forward with the national scope of practice that says to be a paramedic, you have to be a degreed professional, which I'm not opposed to. That's how some of the nursing license started moving up in the ranks in pay, is they started requiring people to have a degree. RNs back in the day, we had most of the RNs coming through were certificate programs. They actually worked their way in the hospital, started off as a nurse's aide, and then moved into that first level nursing position, LVN or LPN, and then became a certificate RN. They had the program where their hospital could approve them based on the amount of hours and contact with patients they'd had, to where that they would be able to take the state exam and actually be covered as an RN. And I think that some of the paramedic programs are moving, into that, where the degree is required. I know Texas, we have the licensed paramedic, which requires a degree, and I've been told that in the next few years that to be a paramedic at all, your degree has to be in place, whether it's strictly an EMS or some degree that lends towards the medical services. I know my original bachelor's degree was not in paramedicine, but it was in healthcare administration, which was able to bring me into the licensed paramedic realm before I did some other training for other things. The components of the EMS system, public access. Most people think that public access is always there. The 911 system is everywhere in every place, and that's just simply not true. In the event of a major disaster, of course, the 911 system is disrupted and access may not be there. But also, it may not be there by the simple reason that you're in a remote area and it's not accessible, it's not set up. And if you were to dial 911 on a smartphone, you might get the next county over, who would have to call the fire department in the local area. So if you're going to work outside of your home districts, you might want to make sure that there is truly access to the 911, and if it is, what kind of resources are available. Medical direction is in that list, and medical direction should always be seen as the backbone and respected. If the medical director says we can do it, that's where we go, but we still have the obligation to determine how safe it is for our patient. Though we're medical director driven, protocol driven, everything we do is based on what the legislature has looked at and allowed, and regulations have been written for us to do. In Texas, we know all about the statute 157 that actually talks about what we can do and how we can stay compliant with the state legislature and the regulations set forth for EMS personnel and first responding agencies. It is continually evaluated. It's integrated into the healthcare systems so that we are a continuation of care and not just a pick you up and drop you off kind of service. The system can enjoy, if it's a municipality, some funding through the federal government, and that comes with some contingencies. If you're running for the federal dollar, then you have to make sure that your training is up to speed and that the equipment is right, and that you are a good steward of what you've been given to work your services. Education systems, that's similar to what we're talking about in this course. You're always required to maintain your education. That includes CEs and continuing education, and to aid in the training of people around you. And you're going to find that the EMS system is actually circular. It's not just becoming an EMS personnel. Again, we're really pushing in this program, our program specifically, that advanced level EMTs are the first stop and continuation of care. And it's very circular. It starts with your dispatch system and moves through public education and then gets to how you're going to be picked up in the ambulance, basic life support or advanced life support. How are you going to make that determination for transfer, either by ground or by air, and then off into the emergency room where other staff, medical professionals, take what you have given them and keep moving the patient forward, trying to get it back to the healthiest position the patient can be into, and then into the next level of health care, which would be prevention and public education, so that people know moving forward what they can do and how they can keep from getting hurt in the same fashion. Access to 911, years ago when I first started doing this, we didn't have the GPS systems. We didn't have the cell phones. We literally had a book. It was called a key map, and you might get a call for a CPR in progress, or there, somebody's down in a field somewhere, and they would give you coordinates based on this book, and you might go to section A4, line 12, spot 6. And once you got there, you'd be looking for a red barn and turn right at the red barn and look for the guy doing jumping jacks in the street in front of a house. That's where you were going. And that's literally how we got there. Today, when I ride the ambulance, they can actually watch me through the satellite system and tell me you're 100 yards from the first left turn. Okay, you're going to move down 300 feet and the house will be on your right. You're looking for a white female, 55 years of age, yada, yada, yada. The whole nine. They can see the entire process. And I've actually been in services. Not only could they see the process of us getting there for the 911 and point of access, they could also see the inside of the back of our ambulances, and we could talk to the receiving physician via Skype or telephone system in the back of the truck, where he could see us, we could see him, and he could assess the patient with us. It's a tremendous move forward, and it's a great step in the right direction for the patients. The complement to that is on the first call, we have the emergency medical dispatchers, or EMDs. These people have been the lifeblood of the guys in the trucks, and if you haven't spent a lot of time in 911 service, I hope you get a chance to be exposed. Having a great EMD means the difference in how you get to and from your calls. I've had many situations where I had a great dispatcher, and they'd have a patient that was critical, and by the time I got there, they had talked them through CPR, they had talked them through putting somebody in recovery position, even as much as helping them go through delivering a baby. And when I get there, the baby's basically just needs to be caught because the EMD had taken their job so seriously and done so well. So I hope you get in a good system with great dispatchers. If you're not, I encourage them to get into a program and become trained and certified. That means the difference for us in the field. For the communication, the dispatcher selects the appropriate agency. It's not always going to be us. Sometimes it's going to be the fire department or the police department, and sometimes it's going to be all of us. So the communication on how we get sent out is extremely important as to what services we're going to render to the patient. These new technologies that we had, I talked about it before. We never had cell phones before. And now I doubt you find a medic on a truck that doesn't have a cell phone. With great power comes great responsibility. Superman's or Spider-Man's uncle said. So I would encourage you, if you're carrying a cell phone, don't be the medic snapping pictures of a bunch of scenes, because that will come back on you at some point. Moving on into clinical care, you see this young medic here. She's fueling her ambulance, so I'm going to say that she's at the end of her shift, because we don't really want to come up on an ambulance in the morning and find it, depleted of fuel. That means somebody didn't take care of their job. It's required by everybody to make sure that their vehicle is prepared and ready for the job for that day. And if that's you, that means you get the job done. It's one of the pieces of being a part of the EMS system. I want to point next at the bottom of that list. It talks about CLIA, Clinical Laboratory Improvement Amendments. I've talked to several medics before and taught a lot of classes and asked them, how do you handle the laboratory testing that you provide to your patients on the truck? And I've been told pretty much across the board we don't do lab testing in the back of the truck. And I asked them the last time they performed a glucometer check on a patient for their sugar, and they're like, well, that's not really lab. Well, it is lab. And if you're performing glucometer checks on patients, then you're required under CLIA. You have to have a license. There has to be a certificate hanging in your station, and that you have to do monthly checks to make sure that piece of equipment is calibrated and up to speed, and that the right strips are available, and all these kind of things have been cared for, so that your patient is going to be taken care of. So it's an all-around circle that we take care of not only just our patients, but our vehicles and our preparedness to get everything going to have the best outcome for our patients. Medical direction. We can't do anything without a medical director. You may carry the best certification in the industry, and I'm talking, you may become a critical care flight paramedic extraordinaire, level 25. It doesn't matter what your level. In Texas, you're going to be medical director driven. You're going to be protocol driven by what that individual who carries that medical license says that we can do and how we do it. And if you don't know your medical director, I encourage you to take the time to give a call, meet that individual. If they're doing any lecture circuits, go to one of their lectures, or invite them out to your service to do a lecture. Medics should know their medical director. It shouldn't be that you've just heard a name and you've never put an eye or a hand to the person who's actually signing off on your license. It will be your benefit, especially as an advanced EMT, to make contact with that person and let them know who you are, and kind of get an idea of where they sit on training. Standing orders and on and offline orders, those are what we work off. We call them protocols most of the time. Never forget that an online medical control is always available. There will be times in your career where you're just not sure what to do with your patient, and reaching out for online medical control is the standard of care. Now, that doesn't necessarily mean you have to have the physician. Your online medical control could start with your dispatch, who has a paramedic there, lead medic, who can run stuff by and bump things off of. They could have somebody that could be sitting there with a protocol book. I know in Houston, Texas, for the longest time, at one of the major hospitals, the trauma center there was a room with paramedics in it that literally had the protocol book sitting in front of them, and medics would call in. Of course, they had so many ambulances running all the time. They would call in and say, this is what I've got. Where are we at on the protocols? How many of this or that can I do? And they would literally talk them through it as they were doing it. Not because the medics didn't know, just because they had a system set up where they could reinforce what they were learning and what they were practicing with. Legislation. When medics get to the point in their careers when the backs don't hold the patients so well anymore, they move into administration a lot of times.